Welcome to PEM Currents, the Pediatric Emergency Medicine Podcast. As always, I'm your host, Brad Sobolewski. In this episode, we're talking about night terrors, also known as sleep terrors, a dramatic, confusing, and often terrifying experience for caregivers to witness, but they're usually benign and self-limited for the child, kind of like a lot of the things in childhood, actually. What are we going to talk about? Well, what are night terrors? How do we diagnose them? How to differentiate them from seizures or other parasomnias? Key counseling for parents in the emergency department. When to refer for sleep studies or neurology evaluation, and what role, if any, medications play. So let's start with talking about what night terrors actually look like. They're part of a group of disorders called non-REM parasomnias, which also includes sleepwalking and confusional arousals. They are not nightmares, and they are not signs of psychological trauma. Children experiencing night terrors typically sit up suddenly during sleep, scream, cry, or appear terrified, show signs of autonomic arousal, so rapid breathing, tachycardia, sweating. They're confused or inconsolable for several minutes, and they have absolutely no recollection of the event the next morning. These events usually occur in the first third of the night, when children are in deep, slow-wave sleep, so stage N3, and they can last 5 to 15 minutes, but trust me, they seem to last much longer to observers. Night terrors occur most commonly between ages 3 and 7, with a peak around 5 years of age. They are rare before 18 months and unusual after age 12. Preschool-age children are most affected because they spend more time in deep, slow-wave sleep. They have more fragmented sleep architecture, and they may not have fully developed arousal regulation mechanisms. Episodes can start as early as toddlerhood, especially if the child has a family history of parasomnias, so like sleepwalking, night terrors, or other things, sleep deprivation, or stressful life events like starting daycare or a new sibling or a move. Although less common, older children and even adolescents can experience night terrors, especially in the context of stress, sleep deprivation, or comorbid sleep disorders like sleep apnea. Why do they happen? Well, they're usually due to incomplete arousal from deep sleep. So the brain is essentially stuck between sleep and wakefulness. Factors that increase the risk or frequency of night terrors include, again, sleep deprivation, recent illness, stress or anxiety, sleep disordered breathing, or a family history of parasomnias. There's a real strong genetic component. Up to 80% of children with night terrors have a first-degree relative with similar episodes. The diagnosis is entirely clinical and based on history. You should ask parents, what time of night do these episodes occur? Is the child confused, frightened, or hard to wake? Is there amnesia the next day, so they don't remember the event? And are the movements variable or stereotyped? Sometimes parents will video record these, and that can really help us clarify the episodes when we're in the emergency department. You definitely do not need labs or imaging in a typical presentation. I think parents are often seeking an explanation for why their child looks so freaky. In my experience, just telling them that it's a night terror and that it's benign and providing reassurance on how healthy their kid is more than enough. Now, not all nighttime events are sleep terrors. You should consider neurology referral and video polysomnography or sleep studies with extended EEG when onset is very early, so younger than 18 months, or late in childhood, so older than 12 or 13. Episodes occur outside of the first third of the night. Again, find out when the kid went to bed and do math. The first third of the night is the first 33% of their typical sleep time. The events are brief, clustered, or stereotyped. The movements are repetitive, focal, or violent, right? So kid just moving their right arm, that's not a night terror. Often the movements will look fearful and they'll be sort of disorganized. Rhythmic movements don't typically happen in night terrors. And there's a recent injury, the child has excessive daytime sleepiness, or there's some developmental regression or abnormality. All those are red flags. Differentiating from nocturnal frontal lobe epilepsy can be tricky. Nocturnal frontal lobe epilepsy events are usually short, highly stereotyped, they have abrupt onset and offset, and they may include dystonic or tonic posturing. So if the family has a video of this, that can be really helpful. Using a good clinical history, video recordings, and EEG generally distinguish night terrors from these forms of epilepsy. But let's be honest, most of the kids you see in the ED with a typical presentation of night terrors are just night terrors. These events are really scary, and we are going to see them in the emergency departments. And so your first goal is to just reassure the family The events are not harmful. The kid isn't aware that they had them, and the child suffers no ongoing psychological harm. That doesn't mean that the parent isn't freaked out or that nervousness doesn't linger. You want to avoid sleep deprivation if possible. Counsel families on age-appropriate bedtimes and naps. Stick to a routine. Consistent bedtime routines reduce sleep fragmentation, which is a known risk factor. For children with frequent or predictable night terrors, try waking them 15 to 30 minutes before the usual episode happens. So I've seen lots of kids with frequent night terrors, and they usually happen around the same time at night. And you want to do this 15 to 30 minute awakening before the usual episodes each night for about 2 to 4 weeks. That's labor intensive as a parent, but it can help. These awakenings interrupt the sleep cycle and break the pattern. Keep kids safe. Use baby gates, door alarms, make sure windows are locked, don't put younger kids in bunk beds, and remove sharp obstacles or objects near the bed. So if they've got a pointy-ended nightstand, well, that's just something for the kid to fall into or smack against. Do we ever use medications for night terrors? Well, almost never. Pharmacologic therapy such as low-dose benzodiazepines or tricyclic antidepressants is really only reserved for severe episodes, kids with substantial risk for injury or disruption of the family life or school in a substantial way. I'm not going to make that call in the emergency department, and these are sleep specialist referral-guided therapies. You also want to consider evaluating children for comorbid sleep disorders, especially in recurrent night terrors like obstructive sleep apnea, restless leg syndrome. This may worsen the parasomnias. For kids in which you're unsure, polysomnography can be used. This is an overnight sleep study that monitors brain waves via EEG, eye movements, muscle activity, heart rhythm, breathing, effort and airflow, and oxygen saturation. But it's also done in a hospital and not during the kid's usual sleep routine. So most children that have night terrors, if you get the right history, you can make the diagnosis clinically, and the kids don't need any expensive or expanded testing to get to the bottom of things. All right, take-home points for this brief episode. Night terrors are common, especially in preschool-age children. They occur in non-REM sleep in the first third of the night. The episodes are very dramatic, but they're benign, and children don't remember them, but trust me, parents do. The diagnosis is clinical. No labs or imaging are needed unless there's atypical features. You should reassure families, promote sleep hygiene, and use scheduled awakenings for frequent and recurrent cases, and refer for sleep studies and or neurology if episodes are violent, stereotyped, or suggest nocturnal seizures. Thanks for listening to this episode. I hope you found it educational about a topic that you will encounter in the emergency department. As with many things in children that are scary, there's a benign explanation, and parents are just looking to know that their kid's going to be okay. Often doing a thorough history and physical and really listening to the parents' concerns and then providing useful information is all you got to do. That's why pediatrics is great. If you've got feedback on this episode or there's other common topics you'd like to hear about, send them my way. If you enjoyed this episode and think that other people should listen to it, share it with them. More listeners means more learners. And if you have a chance, leave a review or like the podcast on your favorite podcast site. For PEM Currents, the Pediatric Emergency Medicine Podcast, this has been Brad Sobolewski. See you next time.